Thank you very much. And I saw Brandon arrived, and also we have many ministry colleagues over here. And this is really a piece of work funded by MOH's National Immunization Program Research. So we won't have much interaction, just give you an update of where we are. We have several presentations, and the first one is a bit descriptive about the incidence of COVID-19 and influenza among the well-Kiwi cohort. So these are the objectives we listed in our proposal. First is to measure the incidence, prevalence, the demographic characteristics, many different stratas, and also the clinical spectrum disease severity for COVID-19 associated acute respiratory infection. And the second one is to identify the etiology, because as I mentioned to you before, we do COVID testing, do flu, and do many other flu, non-flu respiratory viruses. So this is actually a place where you can understand better co-infection, reinfection. And the third is to determine any possible risk associated with COVID-associated ARI. So, and for this presentation, actually I will combine COVID and the flu together, because last year we did have a pandemic situation, both high level of flu and high level of COVID, and they overlapped with each other. And in fact, this potentially can be quite a good angle for us to go through the publication submitted to the journal, because not that many countries have that many cohort study, have two viruses all at the very high peak. So I will do that, describe the incidence and describe the symptom, describe the reinfection, co-infection, and also the future direction. This is a really preliminary result. I only gave you something hot off the press, kind of calculation at the very much at the univariate level of analysis. So first of all, about our number of cohort. As you know, we have about 3,300 cohort members, and it's biased in some way when you compare with the census data. We have lots of babies because of SHIVERS-I, the well-Kiwi infant, and so we have about 40% of those infant, their family joined the household study, so we lump them into household study. And the well-Kiwi adult, we have about 10% of those, and their family joined the household study. Then we recruit a few from the GP patient, from self-referral. In the end, we have 1,800 household members, and from the 513 household families. I will skip the slides because I've been showing you a few times about our overall activities. And so this is our weekly, reports, because we started last year because Omicron came to New Zealand a bit earlier. So started from week 6, 7th of February, all the way till the end of September. So you can see we tested actually here listed is not complete, roughly 5,000. Actually, it's more than that, because if you're counting household transmission specimen, we got maybe 7,000 or 8,000 samples. So a lot of the sample and the testing. And in terms of flu, this is the flu number for those acute weekly survey, have the symptom, get the infection, and we get the test, and it's a flu positive. We are not counting all those household transmission samples here. And in terms of COVID, it's over 1,000 of the COVID-19 positive cases. So look at here, if you look at over the years, pre-pandemic years of this cohort's acute respiratory illness, 2020 is much lower. 2021 high a little bit because of RSV. But if you look at 2022, it's much, much higher than the pre-pandemic years. So then you look at the flu. The flu, we have 2 years without any flu during the COVID pandemic. And last year, it's coming early, sharp, and extremely high. So if you compare the cohort, it's 7 times high than the pre-pandemic years. But if you compare with the hospitalized situation, I think it's about 3 times high than the pre-pandemic years. And then you look at the COVID incidence, we have 2 peaks. This is a PCR confirmed COVID infection, and peak first is probably BA2, second peak probably is BA5, and we just know we got all the results, finished the testing in ESR's sequence laboratory, so later on we probably will know, yes, do they correlate to the BA2 and the BA5 subvariant? And interestingly, just pointed out, this is the area Michael is going to give us more presentation. The pattern of what we see from the cohort is different from the pattern we see from the national notifiable disease data sets. So he will give us more detailed thinking or analysis on that. So the next one is about the compare the flu incidence with the COVID incidence by age, ethnicity, and the sex. So first of all, look at the flu incidence. This is a typical flu infection by age. At the community level, you have young children, 1 to 4-year-old, 5 to 11-year-old, 12 to 17. They are all at the highest. We know the children, school-age children, preschooler, they are the driver for flu transmission. We know that for many, many years. Now, look at the COVID is interesting. New Zealand's COVID incidence by age distribution is probably different from many other countries. We have actually, 12 to 17-year-old, that age group has the highest incidence, and then the young adult and the older adult, and still quite a lot in the children's area, and even the babies. We had quite few COVID incidents in the infection in the babies. Then the flu by ethnicity is interesting. This is a story we know. The Maori Pacific, it really is the most vulnerable, highly affected by flu, and that is the same picture we saw from our 2015 SHIVERS survey. But the interesting about the COVID, actually, you don't see too much distinction by ethnicity, but I do read our weekly survey result every week that the team published. And I do notice at the early days, we actually have a Maori, beginning is the Pacific as a high, leading the whole incidence, and then Maori, and then gradually it's kind of moved evenly. I think probably due to the COVID that has such a high prevalence, managed to get penetrated the Maori Pacific population and move on to Asian and the European population. In terms of sex, flu has been the difference. In terms of male, has a higher incidence, but not much difference in terms of COVID. This slide shows one thing you would be very interested to see is the vaccination. The impact of vaccination, it is protective. I think, Richard showed you about maybe the previous years vaccination may have a bit, not a positive protection, but you have to remember we didn't have flu for quite 2 years. So the VE of last year is enormously good, 70%, 75% of the VE, the crude estimate. Team is still working on the final estimate for that. This is fascinating. about New Zealand's, COVID infection incidence. This 1, 2, 3, 4 is about doses. So you have a booster, fourth booster, third booster, and we don't have many unvaccinated people. But the interesting thing is the fourth booster gives you the best protection, and the second and the third are the second tier, and the first dose is not very much, not as good, not good at all compared with the unvaccinated people. So that is about the vaccination. And 2 minutes, oh my gosh. All right, I'll move on quickly. So you can see from the slides by social deprivation, underlying conditions, crowding, and smoking. Gosh, I have quite a few. But anyway, the slides really give you some flavor about COVID is different from flu. The predictor for COVID is a fever. For flu is fever, we know that. But for COVID, it is a headache, it is a muscle pain for COVID. And this is fascinating because the study, we used the so-called different kind of case definition. Level 1 is only one symptom called ARI, acute respiratory illness. Level 2 is 2 symptoms, fever or feverish plus one of the respiratory symptoms. Level 3, you have to have fever and cough or feverish. That is a typical WHO IOI case definition. And the fascinating about COVID is actually level 1 gave you the highest positive rate. But for flu, it's the opposite. It is a level 2 and a level 3 you have to have. So they present more severe. You have to have more combination of the symptoms. I'll move on quickly. And this is another fascinating. We ask a question about people's severity every time when they have an episode, and they say, do you have a mild, or do you have a moderate, or do you have a severe? Severe means you are hospitalized. Moderate is you have to go see doctors. Mild means you reduce the reactive activity, but actually you don't need to see doctors. And again, flu actually has much high, severity, because they have to go see doctors more than the COVID. You can see here is what's the percentage, 20-something percentage, where here is only 7%. So that's quite interesting, the difference. And in terms of the COVID, the co-infection with the flu, we see, because the peak, you often have a COVID first, then you have a flu second. We have about 120 people in that situation, 2 episodes in the same person. One has, experienced COVID, then experienced the flu, and the children are the one, has much high this kind of episode, 2 episodes all together. And very quickly about reinfection, co-infection, actually it's not a very high percentage. I don't know what is the experience from Nicaragua or Los Angeles, but in New Zealand it's not very high. Yes, this is a preliminary. We want to do more. We don't have final data sets yet. We need to combine all those whole genome sequence data. So hopefully in the next time when we get together, we'll give you a bit more final presentation. Thank you.